Hello friends, today I will be talking about valvular pathologies part 2. Hope you all have gone through part 1. In part 1 I have discussed about all anatomy, functioning and development of cardiac valves plus pathologies related to aortic valve. Today I will be talking about tricuspid valve and related pathologies. These will be tricuspid atresia, tricuspid regurgitation, Epstein anomaly and tricuspid dysplasia. In tricuspid atresia, incidence it is seen in about 4 to 5% of congenital heart diseases. It is congenital heart defect with functionally univentricular heart resulting from atrioventricular atresia. It is most common cause of single inlet atrioventricular connection. It is also known as tricuspid atresia with VST, as VST is obligatory. According to spatial orientation of great vessels, it is of three types. Type 1 seen in 70 to 80% of cases. In it, normally oriented gate arteries like aorta from left ventricle and pulmonary artery from right ventricle is seen. In type 2, it is seen in 12 to 15% of cases. It is associated with DTGA. Type 3 is uncommon, associated with complex great vessels abnormalities like LTG and truncus arteriosus. In diagnosis by ultrasound, in grayscale we can see abnormal four-chamber view with small right ventricle. Size of right ventricle is related to size of VST. In most cases, tricuspid valve does not develop, and at the right atrioventricular junction we can see a thick echogenic tissue. There is inlet perimembranous VST in most of the cases, plus a large interatrial communication in form of widely patent foramen ovale or atrioseptal defect is seen. In 5-chamber view, short axis and 3-vessel trachea view, we can see size of great vessels arising from right ventricle should be checked for presence of stenosis. Severity of stenosis is related to size of right ventricle. Right aortic arch can be present. In longitudinal views, ventriculo-arterial concordance should be checked. In color Doppler, it is needed to confirm the diagnosis and rule out double inlet ventricle. Lack of blood flow across a tricuspid valve, and there is a patent mitral valve. Aliasing is seen across mitral valve due to increased flow of blood. If mitral regurgitation is seen, it has been associated with poor outcome. Right ventricular cavity is filled by blood from left ventricle in late systole and diastole, and flow across VST can be seen. Flow across pulmonary artery is generally anti-gate. Pulmonary stenosis should be suspected when size of vessel is decreased. Flow across ductus arteriosus in 3-vessel trachea view is anti-gate, but can be seen reversed in severe pulmonary stenosis or atresia with small right ventricle. Due to increased preload in right atrium and limited flow across foramen ovale, DV Doppler show reverse A wave, which should not be confused with cardiac failure. Associated findings in tricuspid atresia are cardiac, like large atrial interatrial communication like patent foramen ovale or atrial septal defect, VST, TGA, RVOT obstructions like pulmonary stenosis to pulmonary atresia, or they may be patent aortic cause to aortic stenosis, coarctation of aorta, interrupted aortic arch in TGA, persistent left superior vena cava, pulmonary venous anomalies, or RA can be seen in tricuspid atresia. Extracardiac anomalies can be found in tricuspid atresia, and fetal karyotyping should be offered despite a rare association with chromosomal aberration, including 22q11.2 microdeletions. In differential diagnosis, we can check pulmonary atresia with intact septum. It also presents with hypoplastic right ventricle in 4-chamber view, but it is associated with intact septum and there is always retrograde flow in ductus arteriosus. It can also have ventriculocoronary complications, and there is minimum dysplasia of tricuspid valve as compared to tricuspid atresia, where valve is absent and replaced by thick echogenic tissue. Double inlet ventricle in which two AV valves are there with opening in one ventricle. In tricuspid atresia, prognosis and outcome. Serial follow-up to check patency of foramen or vein should be done, and presence of RVT obstruction should also be checked. DV flow will also reversal, but it is reflection of RV dysfunction, not a poor prognostic sign. In treatment, because tricuspid atresia result in single functional ventricle, operative repair is focused on single ventricle palliation, that is Fontan's procedure, which consists of cavopulmonary shunt, creating a conduit between systemic ventricular blood and pulmonary circulation. Now, tricuspid regurgitation. Tricuspid valve is largest valve in heart and typically has 3 leaflets of unequal size. Choriotympany arising either from small septal papillary muscle or directly from septum are unique to tricuspid valve. Given the complex caudal arcades and their attachment sites, tricuspid valve is sensitive to changes in position and function of free wall of right ventricle as well as interventricular septum. Given large size of tricuspid valve, only 40% annular dilatation may result in clinically significant TR, whereas it is 75% annular dilatation in cases of mitral valve. Normally, tricuspid valve closes during ventricular systole to prevent blood from returning to right atrium with ventricular contraction. In tricuspid regurgitation, blood is ejected back in right atrium during systole. It can be seen from 11 weeks up to term. Tricuspid regurgitation is visualized with color Doppler. It varies in duration during systole, like it can be seen in early systole to the holosystolic regurgitation in which it can be seen in throughout the systole, and in peak velocity of regurgitant jet. Atrial arrhythmia, especially atrial fibrillation, are common in patients with tricuspid regurgitation. Now we can grade tricuspid regurgitation. It can be assessed on color Doppler by width and jet at tricuspid valve and peak systolic velocity of jet and right atrium dilatation. Extent of jet within right atrium, which can be quantified by jet length in right atrium or right atrium area covered. It can be mild with jet length less than 1/3 of right atrium area and peak systolic velocity is 30 to 100 cm per second without any dilatation of right atrium. It can be moderate with jet length more than 2/3 but without reaching opposite wall and PSV of 100 to 200 cm per second. Cardiomegaly is seen but hydrops is absent. It can be severe, jet is reaching the opposite atrial wall with PSV more than 200 cm per second. There is cardiac failure as well as hydrops. In duration, it can be early systolic regurgitation or it can be seen throughout the systole. It is called pansystolic or holosystolic regurgitation. Tricuspid regurgitation in early gestation, it is checked. It is seen if peak PSV of TR is more than 60 cm per second and duration of jet involved at least half of the systole. Method to check TR at 11 to 14 weeks include Doppler sample volume of 2 to 3 mm positioned across tricuspid valve with one crossbar at right atrium and other at right ventricle with insonation angle less than 30 degrees to direction of flow. Tricuspid regurgitation in first trimester is associated with increased nuchal thickening. Chromosomal abnormalities with TR in early gestation are trisomy 21 in 65% cases and trisomy 8 in 30% cases. They can be trivial tricuspid regurgitation. It is mild and non-holosystolic with velocity of less than 200 cm per second. It is fairly common finding around 1 to 5% in fetuses in second trimester of pregnancy. Incidence at 14 to 16 weeks is around 80 to 83% with resolution in most by mid of second trimester. It is diagnosis of exclusion only. Other etiologies have to be excluded. USG follow-up is done and resolution expected in later pregnancy in most of the cases. Pathogenesis is unknown but can be due to immature fetal myocardium that is less compliant and increased pulmonary vascular pressure in pregnancy. In tricuspid regurgitation, what can be their etiologies? They can be primary cardiac etiologies which are involving only pathology in tricuspid valve. This can be Epstein valve pathology, tricuspid dysplasia, or they can be absent tricuspid valve replaced by common atrioventricular valve, which is showing common atrioventricular valve regurgitation. Like here we can see it is a case of AVST. It is in a tricuspid valve and mitral valve are replaced by common valve, showing a AV valve regurgitation. In secondary cardiac pathology, there is pathology other than tricuspid valve. Like in RVOT obstruction, it can be due to pulmonary stenosis, ductal arteriosus constriction, absent pulmonary valve syndrome. In it, there is increased right ventricular volume due to pulmonary regurgitation and obstruction by pulmonary valves. Left heart outflow obstruction, it can also lead to tricuspid regurgitation. Pathophysiology is increased blood flow to the right ventricle in a shunt from left to right across the foramen ovale. Secondary cardiac pathology can also be due to persistent tachyarrhythmias. Risk of TR increases in cardiac defect with complete heart block. Often it is combined with mitral regurgitation due to increased blood volume in low compliant ventricles. In cardiac tumor like myxoma, it can also be associated with TR because it can cause obstruction to inflow as well as outflow. Otherwise, TR is relatively rare in cardiac tumors. In secondary cardiac pathologies, it can also be seen in venous anomalies like total anomalous pulmonary venous connection with absent ductus venosus and abnormal connection of umbilical vein into systemic venous system like right atrium, coronary sinus, IVC or iliac vein, where it will cause dilatation of right atrium leading to increased right ventricular flow and tricuspid regurgitation. TR can also be seen in single ventricle, DORV, and dilated cardiomyopathy with right ventricular dilated. These all are associated with tricuspid regurgitation. Impaired myocardial functions causing decreased ventricular compliance and increased afterload, which can be due to fetal infections, autoimmune conditions, fetal anemia, severe IUGR, twin-twin transfusion syndrome, in which both donor and recipient can be affected. All are associated with tricuspid regurgitation. Here we can see it is dilated cardiomyopathy. Right TR and MR both are seen. Whole of the heart is seen filling the chest. Huge cardiomegaly with tricuspid regurgitation is there. Now to summarize, in cardiac etiologies we can see it can be seen in arrhythmias or it can be associated with dysplastic valve like Epstein valve, tricuspid valve dysplasia or AVST. It can be seen in left heart obstruction like HLHS, coarctation, in right heart obstruction like pulmonary atresia with intact ventricular septum, absent pulmonary valve syndrome, and DA constriction. In venous anomalies, we can see DA PVC and ductus venosus anomalies. Other non-cardiac causes, like we can see TR in fetal vascular anomalies like vein of Galen AV malformation, chorioangioma of placenta, TTTS with vascular anastomosis, sacrococcygeal teratoma, intrahepatic shunt, and intrapulmonary arteriovenous fistulas. Now, Epstein anomaly. Incidence is more common in prenatal series, around 3 to 7%, because of easy detection by cardiomegaly and right atrium dilatation. It is less common in live birth because of increased fetal death due to severe TR and associated pulmonary hypoplasia. It is cardiac malformation primarily involving an abnormal attachment of tricuspid valve in right ventricle. Septal and posterior leaflet of tricuspid valve are displaced inferiorly from tricuspid valve annulus toward apex of heart and originate from right ventricular myocardium. Displacement can be minimal with minor Epstein anomaly to severe form with utilization of entire right ventricle with severe TR. It can be of four types according to Carpentier classification. Type A is mild. There is mild apical displacement of septal and posterior leaflet with small utilized ventricle with adequate right ventricular functioning resulting in sufficient cardiac output. In type B, which is moderate, there is moderate apical displacement with moderately sized utilized right ventricle with reduced functions. Anterior leaflet of tricuspid valve is abnormally attached but with good mobility. In type C, it is severe. There is severe apical displacement of septal and posterior leaflet with abnormal attachment of anterior leaflet plus restricted mobility, which is causing obstruction of RVOT. There is large utilized right ventricle with reduced functions. Type D, it is extensive involvement. Right ventricle is almost completely utilized except for small insufficient infundibular component and all leaflets have severely limited mobility. In ultrasound diagnosis, in Gray scale, in 4 chambers we can see cardiomegaly with increased cardiothoracic ratio. Cardiomegaly is due to enlarged right atrium. Size of right ventricle is dependent on degree of tricuspid valve displacement with severe form leading to utilization of entire right ventricle. Attachment of septal leaflet displaced to ventricular wall instead of valve annulus can be seen in systole and diastole. Here it can be differentiated from tricuspid valve dysplasia where they are seen attached to valve annulus. In severe anomaly, paradoxical movement of interventricular septa can be seen with apical and basal parts showing opposite movements. AST type 2, that is septum secundum defect, may be seen due to dilatation of right atrium due to severe regurgitations. If there is associated pulmonary stenosis or atresia, pulmonary artery is seen smaller than aorta. This is due to decreased flow across pulmonary wall due to severe tricuspid regurgitation. In severe forms, pronounced cardiomegaly compresses both lungs with the risk of hypoplasia. If fetal hydrops or rhythm abnormalities are seen, it indicates poor prognosis. In color Doppler, tear can be seen during systole with origin of regurgitant jet deep within the right ventricle rather than at TV tricuspid valve annulus. In severe cases, jet velocities are more than 200 cm per second and it is holosystolic. Color Doppler of RVOT show reverse flow in ductus arteriosus towards the pulmonary wall or antigate flow in narrow pulmonary trunk when pulmonary stenosis is there. Pulmonary regurgitation back into RV can be seen in severe cases, increasing the risk of fetal hydrops and demise. Here you can see both flows are seen, antigate as well as retrograde, but retrograde flow is more in ductus arteriosus. In severe cases of Epstein anomaly, a fetal circular shunt is seen. In it, tricuspid regurgitant blood flowing in left ventricle through foramen ovale without traversing the lungs. Right ventricle produces insufficient pressure to generate anticoagulate flow. After left ventricle, it is ejected into aorta. From aorta, it goes to ductus arteriosus back to right ventricle through pulmonary regurgitation. Hemodynamic consequences of significant circular shunt include systemic hypoperfusion, ultimately leading to multi-organ failure and fetal death. Here we can see flow in severe anomaly. blood is flowing to right ventricle to the right atrium, from foramen vein to left atrium, then left atrium to left ventricle to aorta, and from aorta to ductus arteriosus. Aorta tries to give blood to pulmonary blood flow, but from ductus arteriosus it comes back to the right ventricle because of pulmonary valve regurgitation, and from right ventricle again goes to right atrium. Associated findings in cardiac abnormalities. There is obstruction to RVOT as pulmonary stenosis or pulmonary atresia can be seen in more than 60% of fetus diagnosed with Epstein anomaly. AST also reported in up to 60% of children with Epstein anomaly, which may lead to right to left shunting and cyanosis. CTGA in around 50% cases and absent pulmonary valve syndrome are also associated. A VST typical of perimembranous type may also be present with or without RVOT obstruction. CT ratio of more than 0.6 in fetus with cardiomegaly is associated with postnatal presence of pulmonary hypoplasia. Supraventricular tachyarrhythmias are common due to right atrial enlargement and presence of accessory pathways. In extracardiac anomalies, we can see cleft lip, cleft palate, congenital diaphragmatic hernia, duodenal atresia, sacrococcygeal teratoma. All can be associated with Epstein anomalies. Most cases of Epstein are isolated finding, but association with trisomy 21, 18, 13, deletion duplication, and CHAR syndrome are also reported. Familial Epstein cases with report of genetic variant in MYH7, TPM1, and NKX25 genes are also reported. Therefore, in workup, amniocentesis for diagnostic karyotype, microarray, all should be advised. In differential diagnosis, we can see tricuspid dysplasia. Here, origin of regurgitant jet helps in differentiating both tricuspid dysplasia and Epstein anomaly. In tricuspid dysplasia, it is at level of valve, but in Epstein, origin is from inferiorly within the right ventricle due to low insertion of septal and posterior leaflets. Severe tricuspid regurgitation with cardiomegaly may also be seen in dilated cardiomyopathy and other non-cardiac lesions. Premature close of ductal arteriosus may also be present with tricuspid regurgitation. A thorough evaluation of tricuspid valve in grayscale and colored Doppler with pulse wave across ductus arteriosus helps in differentiating this anomaly from Epstein anomaly. Prognosis and outcome in Epstein anomaly. The poor prognostic markers include massive cardiomegaly, especially detected less than 22 weeks, decreased RV outflow due to pulmonary stenosis, fetal hydrops, pulmonary regurgitation, pericardial effusion. Compression of lungs may lead to pulmonary hypoplasia. Prenatal diagnosis of Epstein anomaly is associated with poor outcome. An echocardiography grading score called Salamander index can be used for prognostic checking. It is ratio of combined area of right atrium and atrialized right ventricle to that of functional right ventricle and left heart in 4-chamber view at end diastole. Like if it is less than 0.5, prognosis is very good. If it is 0.5 to 0.9, it is grade 2. Then it is 92% survival rate is there. In grade 3, it is 1 to 1.49. Now it is almost poor prognosis is there. In grade 4, it is more than 1.5. 100% mortality rate is there. Another indicator is tricuspid valve displacement index, which is obtained by dividing distance of displacement of tricuspid valve from tricuspid valve annulus by left ventricle length ratio. Tricuspid valve displacement index more than 0.65 is associated with high mortality rate. In management, after birth, immediate concern is adequate ventilation, particularly when marked cardiomegaly is compromising lung development. Some babies are duct dependent and require an urgent systemic to pulmonary artery shunt to maintain pulmonary blood flow, while others do not need. To reverse life-threatening hemodynamic change in circulation, maternal administration of NSAIDs has been used. Now, tricuspid valve dysplasia. It is a group of malformation involving abnormalities of tricuspid valve, where normal anatomic insertion of tricuspid valve leaflet is maintained at the level of tricuspid valve annulus. The spectrum of severe dysplastic leaflet with anomalous chorditendiny insertion to mild lesion involving mild thickening of valve leaflets. In ultrasound grayscale, we can see thickened valve leaflets that do not close properly in systole, enlarged right atrium in four-chamber view. AST can also be seen in Epstein anomaly. As it is seen in Epstein anomaly, here we can also see. In color Doppler, there is severe TR with regurgitant jet arising at the level of tricuspid valve, which is main differentiating point from Epstein anomaly. In tricuspid dysplasia, functional pulmonary artery may develop. Functional pulmonary atresia may develop due to decreased right ventricular blood flow. Pulmonary valve regurgitation is seen. Differentials are Epstein anomaly, pulmonary atresia with intact septum, ductus arteriosus constriction. Associated defects are same as in Epstein anomaly. Outcome with tricuspid dysplasia is very good, except in severe and rare form, which may be associated with heart failure, severe cardiomegaly, RVOT obstruction, severe tricuspid regurgitation, fetal hydrops, fetal circular shunt, and high mortality rate. These are references from where I have taken the content. And thank you so much for your patience listening.